He is our, I always get these mixed up, assistant medical director from Redmond, Oregon. He is the medical director, as you can see there, of EMS and trauma at St. Charles Medical Center. He teaches quite a lot on the EMS circuits up there, conferences and those type of things. And he's been with us for a good many years. His lectures are always extremely helpful. And just like I was talking about a few moments ago, this particular one should help some of you who are struggling with EKGs. And there are some more in the Roundtable links there as well that are similar to these, but you can also put in requests for the docs to teach certain things too. But this one I think you'll enjoy. We've been having internet trouble where I am as well, so I can't guarantee that I will be left on here. I will do my best. Remember, you must participate to get credit. You can't just lurk and not say anything. Ask questions, answer questions. Dr. Eschelbach may stop and ask you questions, and at the end, even if I'm gone, he'll check in with each of you to make sure that you have to participate for credit. All right, Dr. Eschelbach, it is all yours.
All right. My apologies for lateness. One thing about this lecture is everybody will get a chance to answer. So make sure that you can type or talk, unmute, and then I'll be calling on everyone to read EKGs. Now, EKG.
Hey, Dr. Eschelbach.
Yes.
Before you start, I will point out that John Hatch is in 300G. He just started, which means he hasn't got to EKGs yet. But John, just listen in and do this. This will be a head start for you for P2.
Right.
Awesome. Thank you.
Okay. And what my next sentence was going to be, don't sweat it, because by the time you're done, you'll be able to begin what's called pattern recognition. What I like to tell medical students and EMS students alike is EKGs are at first a bunch of squibbles that you don't understand, and as you work your way through them, squibbles that you understand a little bit more. But in your brain, it's pattern recognition. And I keep telling med students and EMS students, you're hungry, it's the middle of the night, it's like it was here, the lights are out, you can't figure out what you're looking for, and you're fumbling around in a drawer and you want to find a fork or a spoon. Now, you know, just by looking at it really quick, if it's a fork or a spoon, or feeling it, you know it's a fork or a spoon. And that's what EKGs are like. The second you look at them, they're going to become either odd or normal. And let's call a spoon normal and a fork abnormal. And I'll explain what I mean as we go through these. We're going to review some basics of EKGs and cardiac anatomy. We're going to review infarcts and ischemia and understand regional changes that happen, and then briefly discuss a STEMI diagnosis, and that's an ST elevation myocardial infarction. We'll not discuss subtle changes, and we'll save that for more advanced cardiology lectures.
Time of death, 1338. Stop now. Good effort, gentlemen. Part of the job, Henry. Sometimes you lose them. No, I didn't intend to bait him. Sorry, it had to be done fast. Was coding. You, want to try it now? He's dead. So? Not gonna hurt him, right?
I'll get a death kit.
Sure. You want to pass, don't you? Try 7.5. Insert it laterally. Sweeping the tongue out of the way. And placing the tip, the blade on the right. Yeah. Oh, yeah. Hey, gently, man. Come on. Easy. Don't want to break his teeth. Advance until you see the cords. brother, what happened? He had a heart attack. Is he gonna be okay? Yeah. Keep going. I think it might be better if you wait outside. I want to be with you. No, I really think it's better if we wait outside. Come on, push the Effie. Another rider after me.
All right. So that's just a little bit about learning things that make you really nervous. So, all right, let's talk about ischemia to infarct. And keep in mind that it's a continuum from a normal state up to infarction. And once heart cells or myocardial cells become deprived of oxygen, their electrical pattern changes in the heart. And this can occur from a lack of blood supply and increased demand. And eventually it will lead to electrical changes that are reflected in the EKG. And keep in mind that is a continuum of the process. So here's an example. Here's a coronary artery. And you go through first ischemia, and that's the start of an injury with a decreased blood supply. And eventually this will lead to from ischemia to injury, and then eventually infarct, where parts of the heart cells die. Ischemia is most notable for ST depression. The normally upright T wave becomes depressed and flips over. The ST segments become flat and they begin to downward slope, and then the T wave eventually will flip. And this is in a regional distribution. And we'll go over this regional distribution in a few minutes. Injury, as it goes from ischemia to infarct, the ST segment now will begin to elevate off the baseline. Go back one, see the ST segment is slightly depressed. And as you go to infarct, you get to begin that ST elevation. Now, if you look at this on the side, this is what we call the typical fireman's hat here. And it'll become more evident as we go along. So as you go from a normal state, P, QRS, T, and you begin to get less and less oxygen, and you get more ischemia to an injury pattern to eventually an infarction pattern, you'll see that the ST elevation begins to come further off the line. You get further ST elevation. Your T wave remains upside down, and eventually you get to the point where you start to develop what are called Q waves, these Q waves which are deep. And as time goes by, you'll recognize this pattern. So that's the pattern recognition that we're talking about. All right. Very quickly, these are the major coronary arteries. These are the right coronary artery, the left coronary artery, and again, as you're looking at this, left is right and right is left because you're looking at a patient, and as they are looking at you, their left is your right. So the right coronary artery goes down the right side of the heart. The left coronary artery goes down the left. And then you get the circumflex, just like the word means, circum means round or around. And you get the left anterior descending, and then you get these smaller coronary veins. And each of these areas of the heart will have a corresponding ST pattern. So these infarct regions, these are the ones that you're going to learn. And I will show you this more than once. Try not to get too upset about it, because you're going to have a cheat sheet in your little folder or book. Your septal leads are V1 and 2. They're supplied by the left anterior descending. Your anterior leads, 3 and 4, are supplied by the left anterior descending. Your inferior leads, 2, 3, AVF, are supplied by the right coronary artery, and your lateral leads, V5, V6, 1 in AVL, are supplied by the LID or the circumflex. Posterior doesn't show up very well on an EKG, but don't forget about it. We'll talk about that and the flip test in a little bit. This is something that you should commit to memory. And as I said, it's in your little flip books, the ones that you keep in your back right or left pocket. And it lets you know as you're looking at an EKG, what that region of the EKG is talking about. So in a 12-lead EKG, we have 12 boxes here. And we know that 1L, V5 and V6 are lateral, inferior, 2, 3, AVF, septal, 1 and 2, anterior, 3 and 4. This will make more sense as we go a little further along. The lateral and inferior region will talk to each other. So what that means is if you have ST elevation in your inferior leads, you're most likely going to have reciprocal ST depression in your lateral leads. That'll become important when we read a bunch of EKGs, not to worry. Also, if you've got depression in your inferior leads, you'll probably wind up with ST elevation in your lateral leads. Why is that? Because they share a common artery as well as region of the heart. There are non-reciprocal changes in the septal and anterior leads. It'll become more important as we go further. I'm going to skip this slide for just a second and this slide and show you just a little bit about refinement when it talks to EKGs. We have refined the EKG when we used to say there was 2 millimeters of ST elevation in 2 contiguous segments. But we did find out that with women, you only need 1.5 millimeters of ST elevation in V2 or V3 to have the ability to call an MI. 1 millimeter ST elevation in 2 or more contiguous leads, that means leads that are next to each other, can also be associated with an MI. In our protocol, and this is a copy of our protocol, if you're not sure, you transmit the EKG to the ER physician for their help in interpreting. Now, keep in mind that not all acute myocardial infarctions or heart attacks are STEMIs. STEMIs are acute MIs that are treated differently by transporting that patient directly to a receiving hospital that has the ability to do intervention. So for example, in my region, one of the hospitals is only 18 miles away from a cardiac center. So even if you're in town and the paramedic reads a STEMI, they bypass the local hospital and drive to the receiving hospital. All chest pain patients should be treated as an emergency, and chest pain without EKG changes could be a potential non-STEMI, which means a heart attack that doesn't show EKG changes. They should go to the closest facility for further evaluation. Talking briefly about acute coronary syndromes, that's a sudden ischemic disorder of the heart where they're not getting enough oxygen. It includes a gamut from unstable angina all the way to MI. And this also represents a continuum. What starts in MI? Plaque rupture, clot formation, vasoconstriction, like this. All right, here is a vulnerable cardiac artery. See this lipid core here? It's very close to the lumen, as opposed to a stable lipid core where it's not so close to the lumen.
Woohoo! Look at that blubber fly!
All right, so when the blubber flies and the lipid core is exposed to the lumen of the vessel and the fibrous cap pops off, like when somebody is under stress, maybe they're shoveling snow and their myocardial intake is going up, then this lipid core is exposed to red blood cells and the beginning of an acute coronary syndrome begins. Now platelets begin to aggregate and they will stick on this fibrous cap and they'll adhere to the lipid core. Platelets will invite more friends, more and more platelets will aggregate until eventually platelets are blocking the artery. Once that happens, you have a thrombus, and then the body releases fibrin here, which is tying all those platelets together, and eventually you wind up with a clot. So you can see vasoconstriction happens, and as vasoconstriction happens, you've got less and less ability for blood to flow through. And eventually, this is going to cause chest pain, angina type pain, pain in the jaw or arm, and then this clot's going to fill up this vessel entirely. What happens when that happens is you get plaque rupture, you increase the myocardial oxygen demand, you get that vasoconstriction, you get that clot, and then your body tries to look for other sources of collateral circulation, and they all wind up leading to tissue death, and that's the heart attack. All right, so let's just attack an EKG. Somebody, whoever is number one in line, it doesn't matter. We'll go over this slowly together. And who's going to volunteer for this first one?
I can do it, Christian.
Christian?
Yes.
Okay. So Christian, let's say you're fumbling around in the middle of the night, you're hungry, you're at the fire station, you want to eat, and you're looking for, we're going to call a fork normal and a spoon abnormal. As you look at this EKG, is it mostly normal, fork, or is it spoon?
I would call it mostly normal.
Good, normal. Let's look at why we would call it normal. Here's a P, here's a QRS, and here's a T. That's good. The QRS duration is short, meaning it's not wide, and it looks pretty regular, right? Now we're going to attack one other thing, and we're going to look at this EKG in the regions. I like to start with inferior, 2, 3, and AVF. As you look at 2, 3, and AVF, do you see any ST depression?
Maybe in 3 a little bit.
Like here?
3.
Oh, yeah, I see what you're saying there, but really it's just kind of going there. But if you look here and there, it's really kind of a straight line. So I would say I really don't see ST depression 2, 3 in AVF. That's my inferior. Now, what are my lateral leads? 5 and 6, right?
Yes.
I'm going to look at 5 and 6. Do I see anything there?
A little ST elevation in the second beat, especially.
You mean right here?
One over to the right, the second beat.
That one.
Mm-hmm.
I'd say I see what you're saying right there, but maybe it's just a little bit of a baseline changing. All in all, because it goes right back to here and the one before it is absolutely normal. And if we look here and here, we see the same thing. So I wouldn't really call this elevation. I see what you're saying, but if I look, I'm given 3 beats. 1, 2, 3. 2 out of 3 are absolutely normal. And this one is a little tiny bit up, but not too bad. So now I've got inferior and laterals pretty normal. Then I'm going to go now for my septal here and here. Looks pretty good to me. How about you?
I agree.
All right, now my anterior here and here, that looks pretty good, doesn't it?
Yes.
So altogether, I've got 2, 3 AVF normal, 5, 6, and my 1 and my L look normal. And then the rest of my stuff is normal. So what would you call this EKG?
Normal sinus rhythm.
Oh, normal sinus rhythm. Normal EKG. Good job. All right. So you volunteered first and you got the easiest one. So good job. All right. Who's number 2?
Why not?
Okay. Why not? What's your name?
William Little.
All right. Will, how about this? Is it fork, which is normal, or spoon?
I'm going to say spoon because I'm already seeing ST elevation in the
All right, excellent.
septal leads.
Excellent, Will. Let's see where we're seeing it. Let's go through this systematically. 2, 3 AVF. What do you see?
Little depression AVF. Other than that, looks no, 2 and AVF both have ST depression.
Yeah, a little bit of depression there. Okay, there might be some ischemia going around. All right, good. Now let's go to our lateral leads, V5 and V6. I'm not too impressed. Right here, you see a little bit, maybe. So keep that in mind, but I'm not too impressed. Okay. How about now my septal leads?
Pretty massive elevation V1, V2, and then I can already tell we got pretty big elevation V3 and V4.
3 and 4. So we've got anterior changes, and V3 and V4 are septal changes. So it's 3 o'clock in the morning. Are you going to activate the cardiac team and go directly to the heart center, or are you going to bring them to the closest hospital, which is a minute away?
They're going to the heart team.
All right, good. So you're going to wake up the cardiologist at 3 o'clock in the morning?
Oh, yes.
All right. Good. There we go. Good job. All right. There was ST elevation that he quickly found. No Q waves yet. ST depression, 2, 3 in AVF, mild, but it was there. And this is the type of patient who might have rhythm changes. So you got to watch this person very quickly. Great. Next volunteer.
I'll go.
All right. What's your name?
I'm Jenny.
Emily?
Jenny.
Jenny, got it. All right. Here's your EKG.
Oh, yay. That's
All
for
right.
sure spoon.
Spoon. Okay, spoon. What are you going to feed to me? Let's read this systematically. 2, 3 AVF. What do you see? 2, 3 AVF.
Definitely some some depression.
Good. That's pretty deep ST depression.
Mhm.
Good. And then my lateral leads are V5 and V6. If this is my baseline, what would I call that?
I would call that some elevation,
Good.
at least 2 millimeters.
All right. And then V1 and V2 doesn't look too good.
No.
V1 looks pretty good. V2
Right.
does not look good. And
Right.
V3 and V4, they also look bad. So this is pretty obvious. And what would you call this then? You think it's an MI, and you've got ST depression with also elevation in our lateral leads.
So, I mean, just lateral MI?
Yep, anterior, yep. Anterior lateral MI, because remember, we've got anterior septal. It's a pretty much ST elevation from V2 to V6. You're going to wake up the heart team?
Absolutely.
Okay. All right. So ST elevation, V1, V2 and V3, V4 and V6. And she called an MI. She woke up the team and she gets the prize. Good job.
And thank you.
All right. Who's our next volunteer?
I think it's me.
Okay.
I'm kind of green.
Okay, that's okay. All right, if you're green, I'm going to tell you that the machine says cannot rule out acute MI. Cannot rule out acute MI. And you're looking at it and going, what do I remember from Dr. Eschelbach's lecture? I remember to go through it systematically, and maybe I can find something. So let's go through here. 2,
Okay.
how's 2 look?
Pretty normal to me.
Yeah, you're right. It does look pretty normal. I'm not too scared by 2. How about 3?
Yeah, I don't, looks maybe a little bit of depression.
Yeah, there's some depression. Here's my baseline, and there's 1, 2 blocks of depression. So 2, 3, and 2, and AVF is also a little bit depressed. So I've got some depression, which means some ischemia, right?
Right.
Then I'm going to go to my lateral leads, V5 and V6, and normally these T waves are upright, and now they're
Right. They're
down.
not.
Okay, so I've got ischemia. Do I see anything else? This is not, V1 has normally an upside down P, that's okay. And then I see, gosh, is that 1 millimeter here? Maybe that's 1 millimeter of elevation, but I don't see anything there. So all in all, I see some flip T waves,
Okay.
but I'm looking at this person and they're sweaty. They're complaining of left arm pain. They're also complaining of pain in their jaw. And let me look at a few other leads. Look at 1 and look at AVL.
Okay. Yeah.
What do you
I-
see?
Looks like it's a little, is it the ST wave is up a little bit?
Yeah, it is. It's almost 2 blocks up. So
Okay.
now I know that I've got ischemia in my inferior leads with ischemia in my lateral leads, but 1 and AVL, which are also lateral, are elevated. And
Right.
it cannot rule out acute MI. So here are your choices. Repeat the EKG in 3 minutes or wake up the heart team.
Probably repeat in 3 minutes.
Okay. Well, what this was an early MI.
Okay.
AVL was kind of flat, as we said, but it was elevated. There was diffuse T wave inversion. So this was an early high lateral MI, And when you repeated the EKG in 3 minutes, these flipped up and they were
Okay.
elevated. So you did the right thing, and you looked at it and you approached it. So what was your name again?
John.
All right, John, that was a good job because that's a hard EKG.
Oh, thank you.
All right, who's next? I have 6 participants.
I think that's back to Christian.
All right, Christian.
I'm back.
All right, what do you see, Christian? Is it a fork or a spoon?
That's a fork.
Fork is normal, spoon is abnormal.
Oh, spoon is abnormal? Then it's a
Yes.
spoon.
Okay. All right, it's a spoon. Tell me why it's a spoon.
I have ST depression in 1, AVL, elevation in 2, 3, and AVF.
Okay,
So inferior.
all right. V1, V2, how are they?
They look pretty good.
Okay, V4, V3 and V4.
These 3, they are okay.
Yeah,
V4, yeah,
okay.
better.
V5 and V6, not too bad.
Nothing.
Okay, so with this elevation here and here and here, and you've got some reciprocal changes here, what are you going to call this?
An inferior infarct.
Acute inferior infarct. Okay, you're going to wake up the cardiologist?
Yes, I would.
It's Dr. Jones. He's always grumpy. You're going to wake him up?
Sorry, he chose the job. I have to be awake too.
Okay, you're right. Absolutely. There you go. Acute ST elevation, and you've got all the changes. Okay. Who's up next? Will?
Yes, sir.
Okay. Fork or spoon?
I'm gonna go ahead and say spoon.
Okay, it looks
Looking
Spoon.
too.
Weird looking.
Yeah. I don't know if it's because of the rate or if it's in like a 2-1A flutter. Let's see. Yeah.
Let's see. Well, let's put it this way. Let's look at our rhythm here. Here's our rhythm strip.
Right.
Is there any variation?
Not particularly.
Yeah, it's a little tachycardic, so it's a little fast. So you're right. You see a lot of these P waves or T waves, but they all map out. They all look the same. So I don't think it's a fib or a flutter. So
Okay.
that being said, attack the EKG systematically.
All right. Let's see. 2, maybe a little bit of elevation there.
Mhm.
3, we got some pretty good elevation.
Okay.
AVF elevation.
So we've got
1.
acute inferior ST elevation.
Yes, sir. Looking to 1, nothing really. AVL, maybe a little bit of depression, but probably not enough to be
Yeah,
significant.
nothing too bad. Okay.
V5, V6, we've got good elevation on both of those.
Okay.
Good depression in V1, V2. V3, no real elevation. V4, elevation. So there's just, I think the involvement in this point is, it's going to be inferior lateral.
Mm-hmm. Inferior lateral MI. They're going to wake up nasty Dr. Jones.
Yes, sir.
Okay. Inferior lateral MI early. You're right. You picked out all the changes. And V4 is also a little elevated. Just slightly right there. But it doesn't matter because we've got enough changes in the symptomatic patient. We already woke up Dr. Jones. He's making 3 times as much as us as he sleeps. So let's wake him up anyway. Okay.
Dr. Eschelbach,
Yes.
can I ask one more question to the last EKG?
Sure. Right here we are.
DST depression in V1 and V2, since they shouldn't be reciprocal, could this be an indication for a posterior wall involvement?
That's a good question. And the answer is possibly, but with ST, with posterior changes, these ST depressions are really deep. And I'll show
Okay.
you one in a minute. They're
Okay.
really, really deep. Now, the question is, does it make a difference? And to me, no. Maybe to the interventional cardiologist, it might make a difference. But if I were to flip this over, which I'll do in a few minutes with another EKG, we can see those changes. So that's a really good pickup that you've got these ST depressions here, but they're not quite deep enough to call a posterior.
Okay, thank you.
But yes, you're right on track with that thinking. Okay, here's our next one.
I would be up again.
Okay, what do you see?
I see a spoon.
Okay, it's spoony.
It is spoony. So 2-3 in AVF. Depression in 2.
Mm-hmm.
Some depression in 3 as well.
Yep, and AVF.
And AVF as well, yes.
Good, all right. 2-3 in AVF. Now, let's check out our lateral leads. 1, AVL.
Those are also, they have some depression.
They do have depression. Good. V5 and V6.
Also depression.
Okay. V1.
It wants to be elevated.
Yeah, but the truth of the matter is it's normal. That right.
It is normal, okay.
Yeah, but V2, V3, V4 are all kind of depressed, aren't they?
Yeah, they are.
So now what I have is kind of global ST depression. So I give this person some nitroglycerin. I started an EKG. I start an IV line. They're not hypoxic, so I don't give them oxygen. And a couple minutes later, they're saying they feel better, and the EKG goes back to normal. So what we have is global ST depression, which can happen with angina or people who have bad coronary artery disease. And maybe they're getting a little bit of cardiac arterial spasm. Maybe they're getting not enough demand. Maybe they're getting early heart failure, but they're not a STEMI, but you follow your ABCs and they start to feel better. And they feel better and the EKG starts to look better. So do you wake up the cath team or you transport them to the local ER? Local ER is 3 minutes away, cath team's 25 minutes.
I would likely just transport to the local ER.
Yep, that's good, because I might do some blood work and I might keep them 6 hours, or I might even admit them overnight and continue blood work. And the answer for that one is correct. No STEMI. I didn't wake up the cardiologist, and they got better. And that's right. All right, John, I think you're up again. Good job.
Yes, sir.
All right. We're about halfway through. What do you see here?
I think I see a spoon.
Okay, you see a spoon. Doesn't look quite absolutely normal. Tell me why it's abnormal.
On 2, it looks like it's elevated.
Uh-huh.
And
About
same with
3?
3.
and AVF?
Yes.
Okay, so 2, 3, and AVF are elevated. Let's look at 1.
Yeah.
A little bit of, what that
like-
is right there. There's a little bit of depression there.
Okay.
And then in this AVL, there's a little depression.
Right.
here.
Okay.
And then I'll look at V5 and V6. They're not too impressive, right?
Right.
All right. So now I look at my septal leads.
Okay.
Maybe a little slurring here. The word is slurring, but
Okay.
nothing too bad. And V3, V4 are not too impressive. So
Right. Okay.
do I have a criteria for an MI?
I honestly don't know.
Well, the answer is 2, 3, and AVF show infarct.
Okay. So yes, right?
Yeah, the answer is yes.
Cool.
Okay.
Awesome. Thank
And
you.
ST elevation, MI, 2, 3, and AVF.
Awesome.
All right. All right. Next, Chris.
Yes, sir.
All right. Take your time. What do you see?
It would concern me a little bit, mostly because of V1 and V2, probably.
Okay.
Also, I'm not so sure about lead 2, what that little notch is there. We have inverted T wave in inferior leads, actually in most of them. And the ST elevation in V1 and V2, otherwise very regular.
Okay. So we know it doesn't look quite right. And then what would you say about the overall QRS pattern?
They're all wide.
Okay.
Most of them seem to be notched,
Yeah.
like in the bundle branch block or something.
Yes. There you go. All right. This is the one that probably causes 95% of misdiagnosed EKGs, because we're looking at these going, hey, look, those are firemen's hats. I remember those. Pattern recognition, right? But as we look at this, our QRS is pretty wide and it's notched. It's notched here and here, and it's notched everywhere. So what we have here is actually a left bundle branch block. And this is, what happens in a bundle branch block is, we call it a hitch in the giddy up, right? The P wave shows atrial depolarization that goes to the sinoatrial node, right? And then at the sinoatrial node, it depolarizes the ventricle and it splits at the bundle of His into left and right bundle branches. And usually they're so close together and simultaneous that the QRS is narrow. But if one side is slightly faster than the other, we get this little notching, which widens the QRS, and we get a bundle branch block. So we really can't call a STEMI on a bundle branch block. Now, as you get further into your EKGs, you'll learn about Sarkozy protocols and all that. But for now, just learn that with a bundle branch block all bets are off. So diagnosing an acute MI in a patient with a left bundle branch block, is so fraught with peril. The safest course is to never try and make that EKG diagnosis. So that it was kind of a trick, and that's okay. I think you figured it out. All right, QRS duration is widened. All right, next one.
Howdy, howdy.
All right. Fork or
To-
spoon?
Well, I would say spoon, but again, V1 looks like we've got the left branch bundle block pattern. We got a QRS greater than 120 milliseconds. Then we go down to V6. It looks like there's a prolonged R time. So I'm going to go ahead and say it's a left branch bundle block.
Okay. And it's a widened QRS bundle branch block. The QRS is down. See how deep these depressions are? Let's look at the one before too. 1, 2, 3, how far down they go. That's also another killer clue for bundle branch blocks. And all bets are off with those. So when you see a bundle branch block and it looks scary at first, keep in mind you're looking at the duration, and then you went to 1, you went to V6, and then you look at your V1, V2, and V3 and see how deep they are, so you can be confident that it says bundle branch block. And the thing about your computers, they will almost always pick this up. They'll pick up bundle branch blocks and your computer reading of your EKG. Okay, very good. Next.
Okay. Okay, so wow, definitely a spoon.
Okay, definitely a spoon. Doesn't look
Okay.
right.
Appears bradycardic, so rate's slow.
Rate's really slow. What is
And
the rate?
my
If I
goodness,
told you that this line and that line are 3 seconds apart.
yeah, it looks 30 beats per
Yeah,
minute.
rate's about 30. So here's a P wave. Here's a P wave and a big long gap.
So type 1. Wait a minute. Sorry, let me revisit my rules. Hang on. So the P wave,
Let's talk about heart blocks really quick.
yeah, I'm getting them confused.
In 30 seconds, is the P wave getting longer? No. It's not a winky block. It's not a second degree heart block.
No.
So it's not a second degree heart block, and this person looks kind of ashen and sweaty, and they're complaining of chest pain.
The third degree.
Yeah, it's a third degree heart block. Yeah. Is there a left bundle branch block in there? Could be, but based on the rhythm, it's more like an escape rhythm. What happens is your P wave, your atria fire, and then it's waiting and waiting, and finally the ventricle says, "I'm not waiting any longer," and it fires. And then same here, same here. So this gap is very large. It's almost 2 blocks, and greater than 1 block is considered a heart block, right?
Mm-hmm.
The T waves are really tall, and what do you think this person needs? Let's say they're on no medications.
So with the rate alone, I mean, I'm thinking atropine.
Right, okay, we give them a little atropine, 0.5 milligram of atropine, and it speeds up a little bit. and then they start to go unconscious, and you throw the pads on, and what do you do?
Start pacing.
You pace them. Because this person, if they're not on any medications, they're in complete heart block, they need a pacemaker. Let's say they were on a beta blocker. If they're on a beta blocker, they might need temporary pacing and wait for that. Maybe they took too much of their beta blocker. And they might need to just be admitted and paced a little while with a temporary pacer. But you transport them and the atropine's good, and atropine didn't completely work, so we pace them and sedate them and get them to the ER. Good job.
Thank you.
All right. John, you're next.
All right. I'm gonna say spoon.
Okay.
2 looks like it's got a little bit of depression.
Uh-huh.
Um,
I'll help you here.
3, yeah,
This
go for
is depressed because here's my line.
right. It's a little low.
Yeah, it's a little low. And then AVF has a little bit of a
Right.
downward depression. So 2, 3, and AVF are depressed.
Okay. All right, and then let's go to 1. Looks normal to me, a little bit.
Okay.
It kind of seems like drawn out, but I'm not. This is pretty new to
That's
me
okay.
still.
It's
So
very subtle, but there's a little bit of down slurring here.
okay.
This looks pretty good. And then we look at 5 and 6, unimpressive.
Right.
And
Okay.
again, in 6, maybe a little bit of down slurring. But all in all, I'm not super impressed with the lateral leads.
Right. Okay.
So
And then
2 shows depression. Lateral doesn't show much. Let's go now to 1.
right. Okay.
What do we see there?
Is this is don't they call these tombstones?
Yeah, these are tombstones. Absolutely.
So
These are tombstones. Tombstone, tombstone, tombstone. And that's a fireman's hat.
right. Okay. Okay. All right. So definitely seeing the spoon on the V1 through V3.
So what do you want to call this?
Definitely I don't know. I would say an MI, but not sure technically
Okay.
what to call it.
Well, we've got septal elevation and anterior elevation, and
Okay.
it's actually anteroseptal, and
Okay.
that's just by definition. And it's an MI, no Q waves, ST depression in 2, 3 and AVF, and a little bit in V6, which we've got.
Gotcha.
And
Okay.
this guy can go into some rhythm changes too. And we're okay. So we woke up the cath team, and this guy needed to go. So good
Nice.
job.
Thank you.
All right. We've got a few more. Who's up? Chris, right?
I think it's me again. Yes.
Okay.
Okay, that's surely abnormal, no doubt.
Okay.
We have ST depression in the lateral leads, 1 ABL, V1, V2, in depression in V2, V3, V4, and elevation in, I would say even in 2, but for sure in 3 and AVF, so an inferior.
Okay. So you think that's an MI?
The reciprocity doesn't add up all the way.
No, it doesn't. Something's something's wrong here.
Could this be something like pericarditis or with the
Well,
overall changes?
No, you're getting closer, but I think it was you who interrupted me and asked me about,
The posterior.
yeah. So now I've got inferior elevation, right?
Mm-hmm.
And now I've got deep ST depression in V2, V3, and V4. So that's why it's not quite adding up. One in AVL, that you would call that depression, right?
Yep.
Okay, and you've got depression in V5 and V6, and then elevation in 2, 3, and AVF. So now I've got way back here, this is probably an acute inferior posterior MI. And that's what we have. ST elevation 2, 3 AVF. And what did the answer was right here, and we didn't catch it. What's that? V4R.
Oh, I didn't
This
see
is
that.
a
Yes.
13 lead EKG, right?
All right-sided. Yep.
So a right-sided EKG shows ST elevation, and it's confirmed with your ST depression that you talked about. I thought for sure that you would smoke me with this, but I tricked you, I guess. But you saw the big ones, but not this guy right here. Okay.
Yep.
All right. Good job. Okay, who's next?
I'm up.
All right. What do you see?
Spoon.
Okay.
Doesn't look normal, certainly. 2, 3. Can't really tell. Let's see the QRS. Looks like we're seeing elevation 2, 3 AVF. We're also seeing it 1 AVL. It looks. I can't tell if that's depression.
It doesn't look right, right?
And it doesn't look right. I'm going to assume, because it's something that we haven't covered yet, maybe that's kind of cheating, that it's a right branch bundle block.
Well, it's not a bundle branch block, although it looks like a bundle branch block. What else do you see before every P and QRS?
Pacer spikes.
All right. What happens with a pacemaker?
It's external electronic stimulation of the heart.
Yeah. So that's why a pacemaker, when it goes off, you just see this ventricular pattern here. So you would almost say, oh, it's a bundle branch block, but it happens right before a pacer spike. And again, it's a trick. Sometimes the pacer spike is not even noticeable, but this was pretty noticeable here. So you can see the pacer spike right through there.
Right.
So that's okay. What it is a paced rhythm. And you put your hand on the chest and you can feel you feel the pacemaker under the skin. Okay. All right, 2 more.
Knee.
All right.
Okay. It's very interesting. Okay, so what is a spoon?
Okay, good. Spoon doesn't look normal.
Right.
That's good. So let's go through it systematically.
Uh-huh.
2, 3, and AVF. They don't look completely abnormal. This looks a little weird here, but it kind of disappears.
Uh-huh.
And maybe I could talk myself into saying, well, maybe it's ST depression, maybe. And then I look at my lateral leads and I'm not too convinced there. I look at 1 and AVL and I'm all of a sudden inferior and lateral, they just don't add up to a whole lot.
Right.
So now let's go to our septal and anterior leads.
And those are showing depression.
All right, pretty good depression.
Yes.
So,
As well as 3 and 4. V3
yeah.
and 4.
So 1, 2, 3, 4. If I were to take this and turn it upside down and hold it at the light and read it backwards, what might I see?
I mean, you'd see it as elevation.
Yeah, so let's see. That's what it looks like when I hold it upside down.
So is it a progressing MI?
It's a progressing posterior MI.
Posterior MI. Okay.
Yeah, so that's the trick. When we do that, we take that and we flip the paper, and when we flip the paper away from us so the writing's on the other side and upside down and look at it, those ST depressions now look like fireman's hats, and that's a posterior MI. So that's the trick. So that was it. All right, one left.
Is this it? All right. So all right, so 2, I'm seeing, is that an elevation?
Yep,
Of-
2, 3, and AVF are elevated.
Are all elevated.
And then 1 and AVL are depressed.
Okay.
V5 is pretty normal. V6 is depressed.
All right.
And V2 and V3 are depressed.
Okay. Definitely a spoon. I'd say MI, but that's just because I'm
Yep.
kind of
Yep.
just, that's all I got right
This is
now.
this is what you're gonna see on your readout, acute MI suspected.
Okay.
And you're gonna see 2, 3 AVF, and you're gonna see reciprocal
Right. Okay.
depression, and you're gonna say, I think this is an MI, and you're gonna call a heart one and activate the team.
Awesome. Thank you.
All right. So now what is, we go home and we study and we look at basic EKGs, rate, and then rhythm, and then axis, and then hypertrophy, and we learn our abnormal VFibs and atrial flutters and AFibs. But now we've got a really good understanding of regional changes in the heart and what that does. And then we've got a good idea of what an MI is. And once we study more EKGs, we'll be ready. So, very good. Any other questions?
Wow, this was a great group tonight, and it was just the right size, I think, for this to work out well. All right, good job, folks. And John, I'm especially proud of you, considering you're in P1.
Yeah.
Thank you so
Very,
much.
very good work.
That was a really good lecture. Thank you.
All right. Thanks. So EKGs aren't so scary.
I'm proud of all of you.
All right. You did a good job, everyone. Thank you. Good night and have a happy
But
Thursday.
that's good.
All right. Bye, Jane.
All right, so I'm going to close this meeting for the night, and for those of you who tomorrow night, thank you, Dr. Eschelbach.